Hello, and thank you for being here today. I'm Dr. Sarah Goldstein, and I'm a cardiologist at Yale. I specialize in cardio-obstetrics, or the care of pregnant patients with heart disease. I'll be reviewing the impact of pregnancy on cardiovascular health. Although pregnancy can be an exciting time for many patients, the changes the body must undergo to sustain a healthy pregnancy can lead to significant stress on the heart and cardiovascular system. In the United States, the rate of maternal death related to pregnancy has been increasing over the past 30 years, with cardiovascular disease serving as a primary driver of the observed worsening outcomes. Cardiovascular disease is now the leading cause of death related to pregnancy in the U.S., accounting for almost 30% of all maternal mortality. Although much of the burden of heart disease affecting pregnancy is attributed to conditions that are present prior to conception, there are certain forms of heart disease that are specifically caused by pregnancy. Peripartum cardiomyopathy is a rare but serious disorder in which certain pregnancy-related changes damage the heart muscle, causing the heart to become weakened and sometimes dilated. This can lead to heart failure or backup of fluid and pressure in the body, which can then lead to symptoms like shortness of breath and swelling. This condition, by definition, develops towards the end of pregnancy or within a few months after delivery. Although in many cases the heart damage is reversible with appropriate medical care, heart function may never completely recover in some patients. For patients who develop peripartum cardiomyopathy, close follow-up with cardio-obstetrics and heart failure specialists is imperative to optimize recovery. Spontaneous coronary artery dissection, or SCAD, is another rare condition that can occur in men or women of any age, but patients who are currently or recently pregnant account for 1/3 of all reported cases. This indicates that pregnancy is a particularly high-risk time for this condition. SCAD occurs when the wall of one of the coronary arteries, or the blood vessels that supply blood and oxygen to the heart muscle, tears and becomes blocked. This can lead to chest pain, injury to the heart muscle, and heart attack. The treatment of SCAD during pregnancy differs from other causes of heart attacks, so it's important that patients affected by this condition receive specialized cardiology care. Preeclampsia is another serious pregnancy complication characterized by new or worsening hypertension and associated organ damage. Although the dangerous effects of preeclampsia and other pregnancy-induced hypertensive disorders were traditionally considered to be confined to pregnancy and immediately after delivery, it's now understood that patients who develop preeclampsia are at increased risk for cardiovascular disease later in life, including chronic hypertension, heart attacks, strokes, and heart failure. To reduce their risk of future heart disease, patients who develop preeclampsia benefit from cardiovascular risk factor assessment and treatment early in life, as well as special attention to lifestyle modifications such as implementation of a heart-healthy diet, regular exercise, and smoking cessation. Finally, pregnant patients with cardiovascular complications may face barriers to breastfeeding after delivery. There are many benefits associated with lactation and breastfeeding for both the mother and her infant. In particular, breastfeeding is associated with reduced rates of cardiovascular risk factors later in life, including high cholesterol, high blood pressure, type 2 diabetes, and obesity. Studies have shown that 10 years after delivery, patients that breastfed or provided breast milk for their infant have decreased rates of cardiac complications as well as death related to cardiovascular disease. It's therefore important that the medical team prioritizes lactation goals in patients with cardiac disease as part of routine care after delivery. Although cardiovascular disease affecting pregnancy can have serious implications on both pregnancy and long-term outcomes, maternal health can be improved and optimized through appropriate multidisciplinary and specialized care from a medical team with expertise in cardio-obstetrics and the care of women with heart disease. Thank you so much for your time. I'll now introduce Dr. Norrisa Haynes.
Thank you, Dr. Goldstein, for your insightful presentation on heart disease in pregnant patients. I am Dr. Norrisa Haynes, and I am a cardiologist at Yale. I specialize in echocardiography and have expertise in global cardiovascular health and health disparities. Building on Dr. Goldstein's discussion, I will delve into how heart disease during pregnancy presents in low and middle-income countries globally. I'll also explore how these conditions contribute to significant health disparities in the United States, highlighting the urgent need for tailored healthcare approaches in these settings. In low and middle-income countries, hypertensive disorders in pregnancy, such as preeclampsia and eclampsia, significantly contribute to the high rates of maternal and fetal mortality. The lack of regular healthcare checkups and delayed detection often lead to these conditions being diagnosed at more severe stages. The management of hypertensive disorders in pregnancy is further complicated by resource constraints, including limited availability of medications, inadequate facilities for high-risk pregnancy monitoring, and insufficient intensive care options. These challenges increase the risk of severe complications, such as premature birth and low birth weight, with long-term health implications for both mother and child. Alongside hypertensive disorders in pregnancy, peripartum cardiomyopathy is another serious health concern in low and middle-income countries. As described by Dr. Goldstein, peripartum cardiomyopathy is a rare weakening of the heart's ability to pump blood associated with pregnancy. The incidence of peripartum cardiomyopathy is higher in low-resource areas. For example, Nigeria has the highest incidence, followed by Haiti, which has the second highest incidence in the world. The higher incidence of peripartum cardiomyopathy in these regions is linked to factors like inadequate healthcare access, absence of early detection methods, potential nutritional deficiency, possible genetic predisposition, and the effects of chronic stress due to adversity. The condition often goes unrecognized until it becomes severe, complicating treatment and elevating the risk of adverse outcomes. In contrast, in the United States, while overall maternal and fetal mortality rates are lower compared to low and middle-income countries, significant health disparities exist. These disparities are particularly evident among different racial and ethnic groups. For example, African American women are disproportionately affected by conditions like hypertensive disorders in pregnancy and peripartum cardiomyopathy, with higher incidence rates and more severe outcomes compared to their white counterparts. The rate of maternal mortality among Black women is more than 2 times the rate of their white counterparts. These disparities are influenced by factors such as access to quality healthcare, discrimination and racial bias, socioeconomic status, underlying health conditions, and the negative impact of chronic stress due to adversity. The recognition of these disparities is crucial for implementing targeted interventions to improve maternal and fetal health outcomes across all communities in the United States. Addressing disparities in maternal mortality involves multiple strategies. These include improving access to quality prenatal and postnatal care, enhancing patient-provider communication, addressing social determinants of health, providing culturally competent care, and increasing diversity in healthcare providers. It's also crucial to conduct research, focus on understanding and addressing the specific causes of these disparities. Additionally, policy initiatives and community engagement play key roles in creating systemic changes to reduce these disparities. These approaches are vital for reducing the high rates of maternal and fetal mortality associated with conditions like hypertensive disorders in pregnancy and peripartum cardiomyopathy in resource-limited settings around the world, and addressing the health disparities in more developed countries like the United States. Thank you so much for being with us today.